Happy to call on a good friend of the Israeli cardiology and of myself personally, the president of the ESC, Professor Panos Vardas, will speak about the benefits of ablation versus medical treatment in atrial fibrillation.
Dear Michael, dear Amit, esteemed friends and colleagues, sorry. I'm really pleased to be here, invited by Medtronic, this very innovative company, to speak about atrial fibrillation. As you know, atrial fibrillation is a very, very common arrhythmia, and my task today in the next 17 minutes is to present a comprehensive comparison between the benefits of atrial fibrillation ablation and the benefits of antiarrhythmics in the management of AF cases. Allow me first to recognize and to consider some realities. It is clear that as the population is aging, the incidence and the prevalence of atrial fibrillation is increasing, no doubt. Then it is also clear that the efficacy of antiarrhythmic drugs to maintain the sinus rhythm is rather modest. And unfortunately, during the last 20 years, we have more or less the same drugs. And of course, it is clear that nowadays our experience around the effectiveness and the safety of the pulmonary veins ablation is mature, is much more clear. Allow me now to concentrate and to focus on four main important areas and to discuss and to analyze very fast indeed these four main areas. The maintenance of sinus rhythm is one. The incidence of ischemic strokes is the second. The quality of life is the third. And of course, we have to spend a little bit time to discuss about the cost and the effectiveness of the two therapeutic approaches. So, in very brief, I will attempt to make a comparative analysis in each of these four areas between the cardiac ablation and the antiarrhythmic drugs approach. First, again, I would like to present this classical slide which predicts that the incidence and the prevalence of AF by the year 2050 is going to be really high. Why so much high? Because the aging of the population, as I said. And progressively we have recognized that this very disturbing arrhythmia is becoming an epidemic. Maintenance of sinus rhythm, the first main issue for discussion. As you know, there are some special issues where we have the patient for atrial fibrillation to be kept in sinus rhythm. Highly symptomatic patients, patients that have a diastolic dysfunction, for example, patients who cannot tolerate the fast ventricular response are some characteristics, example, indicating the need for a maintenance of sinus rhythm. So, as you understand, our task is to do our utmost to keep the patients in sinus rhythm. Once John Cam said in one of his papers that everyone is born in sinus rhythm and anyone likes to die in sinus rhythm. What about the antiarrhythmic drugs? Do we have enough new antiarrhythmic drugs? The answer is no, unfortunately not. We have amiodarone, dronedarone, I will speak for this drug later, flecainide, propafenone, sotalol. And here is a very recent report coming from the American guidelines, which is stated that the following antiarrhythmic drugs are recommended in patients with atrial fibrillation to maintain sinus rhythm, depending on underlying heart disease and comorbidities. dear colleagues, give me just 30 seconds to express my view about atrial fibrillation, as I'm working in research and clinically for 35 years for this dirty arrhythmia. I have a lot of doubts if this arrhythmia is a disease or is a symptom or a condition. Atrial fibrillation is like the cough. It's a very heterogeneous disease, and you have to individualize each case in order to make your utmost therapeutically. So here again, you have mostly old drugs and some new drugs like dofetilide and dronedarone with a modest effect, and you have to individualize your patients, which one of them is going to receive each drug. But you see here, these are the American guidelines. What about the efficacy rates of the antiarrhythmic drugs? Here is clear. Amiodarone is the most effective drug. Of course, this drug is the most dangerous, and please remember that every 5 to 6 months, the TSH of the patient should be tested. In the case that you will recognize any trend of downsloping of the TSH, you have to stop immediately amiodarone, because this drug is very effective but very dangerous to create hyperthyroidism. We don't afraid the hypo, we afraid the hyper, as you know. So, amiodarone is the most effective. What about dronedarone? Dronedarone in those with non-impaired ventricular function works, but this drug, unfortunately, has a modest effect. No comparison with the effect of amiodarone. So here, some classical slides, classical examples. Amiodarone has a, let's say, good follow-up, and it keeps the sinus rhythm in a percentage around 60% in 1 year. Depends all the times from the patients. So the modest effect of the antiarrhythmic drugs is well known, and this situation will not change in the near future. Why? Because we had a great disappointment from dronedarone. And then, 20 years ago, Heisseger was actually not the first who spoke about the role of the pulmonary veins in the induction of atrial fibrillation, but no doubt he is the great pioneer in this field, and he said 20 years ago that the pulmonary veins are an important source of ectopic beats, that they are capable of initiating frequent paroxysm of atrial fibrillation. Don't underestimate the role of fibrosis. Unfortunately, I have not enough time to speak about my view and others' view about the fibrosis, but microfibrosis and fibrosis is the most important issue for AF development, plus the induction, plus the triggers. So Heisseger had highlighted the role of the pulmonary veins triggers, and then the ablation endeavor had started. And now we know that the catheter ablation is effective, and but is not so much effective with only one procedure. If you like to keep the sinus rhythm at a percentage of around 75, you have to repeat at least once this procedure. And these patients from Heisseger group are patients, 63% of them with paroxysmal atrial fibrillation and the rest with chronic atrial fibrillation. That's why the results here are not the best. In this study, coming from Karl-Heinz Cook department, all the patients were in paroxysmal atrial fibrillation, and the results are a little bit better. But please keep in mind that you have to repeat the procedure in a number of patients This slide is very important. You have the opportunity to see a comparison between single procedure success and multiple procedures success. And as you see, those with multi-procedure patients, the success is much higher, no doubt. You see the difference between the 2 or 3 procedures during the follow-up versus one. What about the paroxysmal versus the chronic? This is the difference. The message here is, please select patients with paroxysmal atrial fibrillation. The chronic is not so much effective. And then we had recently the AE4 study, which compared the effects of antiarrhythmics versus the ablation. And the message is clear. The ablation is more effective, no doubt. Especially if the ablation is performed in experienced centers. And then the MANTRA paroxysmal atrial fibrillation study more or less concluded in the same direction, saying, look, the ablation technique is more effective than the antiarrhythmic drugs. As I said, sometimes, not only in very few cases, but in some cases, you have to repeat the procedure. So, according to the MANTRA trial, a third of the people assigned initially to drugs needed supplementary ablation. Ablation was associated with a greater chance of being free from atrial fibrillation at 2 years period. It's clear, the ablation technique is more effective, especially in those patients properly selected. And here is the classical algorithm how to select your patients for ablation or for antiarrhythmic drugs. Question, is then ablation now in the American guidelines and the European guidelines first line choice? Answer is not. It is only first line choice for those patients very paroxysmal as it is indicated here. Paroxysmal atrial fibrillation patients with episodes of symptoms, the ablation is becoming first line choice. Very symptomatic paroxysmal atrial fibrillation. This is the message. And here, the same message is coming from the American guidelines published this last month. A catheter ablation is useful for symptomatic paroxysmal AF, refractory or intolerant to at least one class 1 or 3 antiarrhythmic medication when a rhythm control strategy is desired. Of course, all the times you have to count the possibilities of complications. What about the novel technologies? Yes, we have some novel technologies, more safe, sometimes even more effective, like the Medtronic new cryoablation catheters, and we have this important trial, the STOP AF trial, which more or less concluded in the same direction. Pulmonary veins isolation was achieved with the balloon catheter alone in 83%, a high percentage indeed. At 12 months treatment, the success was around 70% of cryoablation patients compared with 7.3% of antiarrhythmic drugs patients. And here is again the same results coming from the STOP AF patient, which is quite indicative about the superiority of the ablation technique using novel cryoablation catheters. Few things about the incidence of ischemic stroke. Atrial fibrillation ablation patients have long-term stroke rates similar to patients without atrial fibrillation, regardless of CHADS-2 score. So, more or less, the message here and what is stated on this slide is clear. The message indicates that if you use the ablation technique, the success, actually the stroke rates are more or less the same like those patients without atrial fibrillation, and this is quite encouraging. Atrial fibrillation patients who did not undergo ablation had early and persistent lower survival free of stroke compared to AF ablation patients. Another clear message, and of course, if we had time, we have to analyze one by one the scores, the CHADS-2 scores, and the effects of the two different therapeutic policies. But again, here is clear. The strokes rate is lower in the patients with ablation. Using our results from the EuroHeart survey, as it is presented in this slide, we again conclude to the same direction. The ablation group had stroke and mortality rates that were significantly lower than those in the control group, and that approached the risk of the general population, as I said again before. So, more or less, we have, look here, how much high is the medical outcome. The outcomes come based on the medical treatment, and the ablation has really very low rate of stroke. What about the quality of life, the third big issue? Looking backward to the A4 study, we could conclude that symptom score, exercise capacity, and quality of life were significantly higher in the ablation group. Catheter ablation is superior to antiarrhythmic drugs in patients with atrial fibrillation with regard to maintenance of sinus rhythm and improvement in symptoms. Again, another trial which concluded that the long-term quality of life after ablation of AF is higher, is better than antiarrhythmics. And here is the symptoms analytically presented and how the symptoms are doing during the follow-up. Finally, allow me to conclude, and I'm sure that the Medtronic team is happy because I will conclude on time, about the cost effectiveness. Radiofrequency ablation, combined or not with antiarrhythmic drugs for symptomatic drug-refractory paroxysmal atrial fibrillation, appears to be reasonably cost-effective. Ablation is not cheap, but we have to take into account the effectiveness. The cumulative costs with the radiofrequency ablation and antiarrhythmic drug strategies were $26,000 versus $19,000 respectively. So it is true that the cost of the drugs is a little bit less than the cost of the ablation, no doubt. But if we take into account the readmission rates, which is the most expensive reason for the AF cases, if we take into account that the readmission rates are getting much lower in the case of the ablation techniques, the final cost-effectiveness analysis indicates that the ablation techniques are really cost-effective. The incremental cost-effectiveness ratio for radiofrequency ablation was around $51,000, which is marginally but acceptable. As you know, the highest acceptable number for a cost-effectiveness analysis per quali is around $50,000. To conclude, catheter ablation for atrial fibrillation has done significant progress during the last few years. Catheter ablation seems to be associated with lower rates of stroke and death, and from the cost effectiveness point of view, we could say that this technique is cost effective. So again, in this comparative analysis, we could suggest ablation as the best treatment for those patients with very symptomatic atrial fibrillation, paroxysmal form of the arrhythmia, and of course, all the times we have to take into account the significant role of the experienced centers where this technique is performed. Again, thank you very much for your attention.